anywhere. Okay, I'm going to call the meeting to order. We're going to go. Is Jeff Breedlove here? Okay, we're going to hear. I'm going to do the substitute to 474. So I'll call the meeting to order. Hopefully they'll get out. I have to go to a rules committee. A Senate rules as soon as they get out. Okay. Okay. And you know, we have a saying around here is that anytime that you say a simple little bill is brought to you, you're looking for trouble. And I'm telling you, House Bill 474 has been trouble. It's for what I thought was a simple little bill. We are all in this fight against opioids and our problem with addiction in our state to opioids. But addiction also comes not just from prescribed medications, but from the illegal market. And so because of that, it sort of puts us in the dilemma on what we're going to do. This would require, or would put into law a requirement that physicians, when they write a prescription for an opioid of a certain amount, that they would also write a prescription for Narcan. Now, the problem is the bill has no teeth of what happens if they don't do it, or what happens if the person and the patient doesn't fill it. And so as we began to talk about it before, bringing the bill to committee, there were concerns. Dr. Newton brought up one of the first ones, then the Medical Association and the pharmacist. We are having a problem in this state. I got a call this morning. We have put so many regulations on the physicians about prescribing pain medicine that we really have almost scared them to death. And across our state, our family practitioners and the people that patients see first are more and more saying they will not prescribe anything to anybody. And the only way that somebody who has legitimate pain can get medication for their pain is to go to a pain specialist. Well, not every city has a pain specialist. And pain specialists really should be used for our more severe cases, not for the person who comes in and they, I'm trying to think of something, their back is out of whack and for, they've strained it or really pulled a muscle or something. And I can tell you, having done that, you can be in excruciating pain for a short period of time and need something for a day or two to handle it and not to be able to get that. Or like the patient this morning, that's a cancer patient on a cancer drug. That is known, one of the side effects is excruciating pain, especially in the extremities. And even at the pain doctors, when he got referred, they are unwilling because of all the restrictions that we put on them and all, and the concerns of being reported to the board if they, are trying to take care of the patients and somebody thinks it's a little out of whack, in giving enough medication to take care of the patient's pain. And certainly as cancers progress, a person often takes pain medication, or a patient that's dying from some kind of a problem, they get tolerant to the opioid and then need to have the pain medication increased. Now, like I say, I passed one of the very first bills here on the 911 bills that went through in the first Narcan bill, before we were even talking about the addiction problem really on a great scale in Georgia. And I do not want anybody, to become addicted. But on the other hand, it's a really small balance or a really hard balancing act between making sure patients that have realistic pain, that they get the medication they need, and making it so strict that they're denied what they need when perhaps, what we're doing is not the best way to go about it. So with that, I decided that we would have a hearing about it. So we have the committee members like to ask any questions or make any comments. And I will tell you that already on the medical board's website, the medical board has put out the recommendations from the CDC, which does include, ordering Narcan, and it's at 50. This bill has it at 90, and they have it at 50 morphine milligrams equivalents per day. So there's already that out on the medical board's website. Dr. Newton?
A couple of the things that I had a question about, and I guess regarding the bill, was the lines 33 through 35. This is just for a little clarification. When you say that, when it says the prescription for the opioid antagonist or Narcan or naloxone, is the prescription, is that something the pharmacist gives that information? Pretty much it's because Narcan has a half-life that's shorter than the half-life of many of the opioid medications, and therefore you can get relief from it. The patient wakes up, goes and eats something, family feels better, patient goes to sleep, and then stops breathing in the middle of the night because the extended release narcotic or opiate actually has a longer half-life than the temporary of the naloxone. And then when I see the written information, I wasn't sure, is that when you say a prescription shall be accompanied by it, is that the prescription that a physician writes, or is that the prescription a pharmacist hands the patient?
Well, it's supposed to be the prescription that the doctor writes.
Okay.
Okay. Further questions from committee? We do have Jeff Breedlove. Let's start with Jeff Breedlove. And I'm going to have to excuse myself, or we can go to hold if you think I can be back. Why don't we hold that? Let's stop there. Jeff, wherever you are. Can you stay with us? No wonder I didn't recognize you. The hair. Okay. I need to go to rules, and I'm going to turn it over to my vice chair, and I will return. If I don't get back, go ahead and call them, but this is no vote. Okay, this is a hearing only, and I will then watch it back.
Thank you. And this is we'll go on. Let's go on. I see Senator Kirkpatrick is here for SB 5. We can go ahead if you're ready. We'll go ahead and come on up and present for us.
Thank you. You guys have heard this bill before, and it needed a couple of changes. So I will just remind you that it's about outpatient sedation being done in a non-traditional setting. So outside of a hospital, outside of a surgery center. An example would be a med spa or a cosmetic dentistry office, for example. So the changes that we
Excuse me.
made, the original
Senator,
bill just basically.
Just read your LC number for us to make sure everybody's working off the same one.
LC 338713S. Is that what you have?
8713S. Yes,
Mhm.
correct. Go ahead.
Okay, anyway, so basically the premise of the bill is that if you're going to do outpatient sedation, you have to follow the rules of either the medical board or the dental board. Pretty straightforward. But what turned up a little bit later was that in our dental board rules, there are rules that allow dental assistants to do certain procedures such as phlebotomy and venipuncture. And so this bill was amended to address that concern. We also talked last time, I believe, about anesthesia PAs, and I think we've got that all straightened out. That part is on lines 97 through 103, and the new language that we added about dental assistants requiring them to complete board-approved training is the next section, in section 2, lines 109 all the way down to 126. So I think that covers it. I think everybody's happy with it now, unless I am missing something, and I'd be happy to answer any questions.
Thank you for your explanation. We don't have anyone signed up to speak to the bill, but are there questions from the committee? Does everybody recall seeing this bill before? And are there questions? Chairman Hawkins.
Well, this isn't a question. This is a thank you to the author. I mean, I wasn't aware that assistants could do phlebotomies and venipunctures. I think that's a real outlier. I think possibly some oral surgeons that do a lot of IV sedation doing third molars in their offices may have trained some of the ladies to do that. But I applaud what you put in the bill. I think there should be training for that and accountability, because as healthcare grows and it grows, as we're seeing outpatient treatment and surgeries, we need to be ahead of the curve. And so I thank you very much for this bill.
Thank you, Mr. Chair.
Looks like we do have one to speak on the bill. Is that right? Go ahead and introduce yourself and.
Yes,
we'll
sir.
put you on the
Chairman
side.
Newton, members of the committee, my name is Scott LaFranco. I'm with the Georgia Dental Association. We want to also thank Senator Kirkpatrick for her work on this bill. We did work with her on the language, as she mentioned, in lines 97 through 103. And then we also provided the language in lines 109 through 126 to address the dental assistant issue that she was referencing. So we are in support of this legislation. Thank you.
Thank you. Any questions from the committee for the presenter? All right, push your button of it, Will. No other questions? If so, go ahead if you'd like to make a motion. Have a motion to pass and a second. Is there any other discussion on SB 5 LC 338713S? Seeing none, all in favor, say aye. All opposed, no. And if we can check online, if there's a couple of people online, we don't have any negative votes on that, so the bill passes. If you could let us know your House sponsor.
Yes, sir. I do believe Dr. Hawkins is going to help me with this. Thank
All
you.
right, thank you, ma'am. Yeah. Thank you. Okay, we'll go on to Senator Burke. Come on down and tell us about SB 46. Just read us off your LC number as we get started. I see there's a sub.
Thank you, Mr. Chairman. I appreciate the indulgence, and there is a late arriving sub. Just make sure you got 338753S.
Correct. All right, go ahead.
Y'all do great work here. Thank you. Senate Bill 46 is brought to you by the Department of Public Health. It's a department bill. I was glad to support them, considering all they have done for Georgia this past year. So I want to thank the department and obviously Dr. Toomey for all the work she's done for keeping Georgia safe. Basically, this bill is an attempt to update some old code language in regards to the what we call the GRIT system, which is the immunization database that those of us in the healthcare community have been using for years, which we in the legislature has just recently upgraded by our appropriations. So I think we'll be happy with that. This codifies some of the things that have been put in place for the emergency, such as who can give certain vaccines. It's got some concerns I've heard. One, is this a vaccine mandate? It does not. There's nothing in this that requires anybody to get any vaccine. There were some privacy concerns in Section 3 that we worked really hard with folks on the Senate side to make sure they understood that when we're doing the COVID vaccination, our agreement with the CDC is we have to input certain data into their database. We can't get the vaccine without it. So basically that sentence in Section C under the number 1 and under Section 3 on page 3, that language there is the information that we have to have to get the information that the CDC requires on who the vaccine is given to. Megan Andrews is with us from the department, and she can certainly answer any technical questions that are above this country doctor's head. So be glad to stand for questions, Mr. Chairman.
All right, looks like Florida locked.
Thank you, Mr. Chairman. Thank you, Senator, for bringing the legislation. I have a question in the section 3. Who at this time, or does it occur at this time with the vaccines? Are families consenting to it now? I know that in here, on line 51, 52, it says without the consent of the person or the person's parents or guardians.
Well, right now, with the normal immunizations, I'm not outside of COVID, there is an opt-out of reporting requirements with that parents can take if they don't want to any information being reported. We can't do that with the COVID vaccination. In other words, we've got to provide information to the CDC. So for purposes of the COVID vaccine, which right now that's not, 16 to 18 for Pfizer is the only pediatric age group that's approved. So this is not really something that's that important yet. But once it does get approved for pediatrics, then we won't have that same opt-out option available because we can't and still use the federal government's vaccine supply for COVID.
So if you don't mind, can I ask an additional question? So is this specific to COVID? Did I miss something, or does this relate to all vaccinations?
No, just on the first line of C, it says for vaccines administered in response to a public health emergency.
Okay, thank you.
Chairman Hawkins.
Hello, Senator. How you doing?
I'm doing great, Doctor. How are you today?
I'm good. On page 14, now this is more of a scribber thing. I think this is a good piece of legislation, but on line 343, we end with A, and then we pick up on line 330 with the pharmacist, the pharmacist. I know it's a scribber's error. Can we just cut out an A or a the? Oh, well then I need better glasses or some glasses because it doesn't look like that on mine. I apologize. It looks,
I finally found when you were talking about it on my copy, it is marked out, but it is a tiny,
okay,
tiny
I
little dash.
apologize then because I can't see that on this one. So never mind.
That was easy, Doc.
So if I can, Senator, the new language, the current language, the without the consent of the person or the person's parents or guardians, there is a specific exemption allowed in 1963. Is that right? For all other vaccines, and this might be a question for the department. So there is is that okay?
I'll let her answer that if
Okay.
that's okay, Mr. Chairman.
Sure.
So are you referring to the first without the consent? You're talking about lines 51 and 52?
Two parts, the fact that 51 and 52 are currently in code down in line 62, and it just
Yep.
got moved. Is that correct?
Yes, that's correct.
So
So that's
that
not
that
new
applies
language.
to all other, that applies to all vaccines. Is that right?
Yes.
But by putting up here higher, there's a difference for C that doesn't apply to previous vaccinations. Is that correct? C is only
So the-
special language just for public health emergency. Is that right?
yeah, so the without the consent that's in E1 would apply to A, B, and C in this scenario. I think what Dr. Burke was talking about before regarding the no exemption, that is specifically referenced on line 65. So right now, if folks don't want to participate in the GRIT system, they can request an exemption and we don't collect their data. But specifically with regard to the COVID vaccine, our allocations from the federal government are based on data that we report to them. So if people are exempting from the registry, we don't have a record of them receiving this federally allocated vaccine. Does
Chairman
that make
Barr.
sense?
Yes, ma'am. Thank you.
Yeah.
May I make a follow-up on that?
Yes.
Very clear, because I have gotten, my inbox is full of security concerns because of the language.
Mhm.
So let's see, lost my place here. Apologies. So when we do send this information up to the federal side,
Mhm.
we spoke earlier, and it is unidentified. It is not name, address. It
No,
is-
the only identifiable information that is sent to the CDC is the patient's date of birth.
So it would be patient date of birth
Mhm.
and that they received.
The
this
date they were
vaccine.
vaccinated, their zip code, but those data points aren't necessarily identifiable just because of
Sure,
how many records we're sending up there.
very good.
But the birth date is certainly an
Okay.
identifiable data point.
Okay, very good.
Mhm.
Thank you, ma'am.
You're welcome.
Chairman Jaspers.
Number two. Thank you, ma'am. I just want to follow up on Chairman Barr's. Okay, on E1, maybe I missed just the interpretation of it, but I suppose that if a parent were allowing their child to be vaccinated, that they would already have given permission to fill out the information on this. Is that not right?
So you're talking about the without the consent?
Yeah, I'm talking
This
about
is
line 51,
regarding-
52. Why, I guess I'm getting at is why is that in there? Because I would assume that if I were allowing my child to be vaccinated with COVID-19 vaccine,
Mhm.
that I would have already given consent and filled out the forms like many have to do that. I guess I don't see as I think you've heard from two other members, why are we saying without the consent of the person or the person's parents or guardians?
So
That's not-
that language is in existing law. That is on line 62. Legislative Council, when they were drafting, they just reorganized it to make it a little bit more clear. So that's not a change. That's not anything we're adding. It's just being moved from one place to another. And so the authority to share this data without the consent of a person or their parents or guardians, that allows DPH to send data to various medical providers as it's laid out in A, various school or childcare facilities to make sure the kids' vaccines are up to date. And then also C, related to the COVID vaccine. Does that make sense?
Yes, starting to. It seems to me like, let's see. Okay.
And
It just seems to be, I could see how
Yeah.
Representative Barr said, everybody in town's looking at this going, because they're not going to read the beginning of section 3 or even know what code section it's in.
Right,
They're
right,
just saying without the permission of a parent.
right. And I think the important thing to keep in mind is that's not a change. That's how we operate already.
Yeah.
That's an existing law, and legislative council's here and they can chime in about their bill drafting and organizational structure of the bill.
Oh, now, this lady back here wrote it. I'm all in.
Oh, I know.
Just real briefly, and I don't know if we got off too quickly, or is there other things in the bill that it does that you'd like to discuss with us, since it is a department bill that?
The only other
any
part
sections,
that,
and then we'll go to some questions.
yeah, the only other part I want to make sure is clear is section 4. So that's talking about the vaccine protocol agreement. So right now, pharmacists can enter into a protocol agreement with a physician, and then they can administer vaccines pursuant to that agreement. The way current law was structured, that vaccine protocol agreement could only include 4 different types of vaccinations. And you can see that in the stricken language in lines 98 through 100. This bill is changing that, where now they can, pursuant to that agreement with a physician that's supervising them, right? They can administer adult vaccinations according to ACIP guidelines to individuals 18 or older. And then flu or a vaccine, a public health emergency vaccine to individuals 13 or older. So that's kind of the meat of the bill that
Okay.
I want to make sure you guys understand as well.
Any questions on that section? Let's go, Chairman Cooper.
Okay. They can give any adult vaccine if they enter into it with a physician?
Any adult vaccine that's on the ACIP guidelines.
What's
So
that?
that's the advisory.
No, which ones are they?
Oh, I would have to pull a list for you. It would be like flu, shingles. Bethany,
Okay.
or Greg. If you want the list, Bethany can read it
Huh?
off to you.
No.
It would include all of the typical childhood vaccines that an adult would need to catch up on. There are a few childhood vaccines that we don't recommend for adults unless they have very specific conditions, i.e. immunocompromised people who are able to take vaccines may need other vaccines that we don't currently give to other, healthy adults. And then it would also include things like shingles, if you are of the age to receive the shingles vaccine, the Pneumovax or a pneumonia vaccine, if you're that age. There's probably a few more besides the flu vaccine, obviously, which they can currently give. Probably the number one thing that pharmacists cannot currently give under a protocol agreement is live vaccines, and that would include like your MMR, but that's a fairly small subset of adults that would be getting an MMR vaccine, because we are getting to the point where most adults either have had measles, mumps, and rubella or have had 2 MMR doses.
So this would allow them to give those?
Yes, yeah, under a protocol agreement with the physician.
Okay.
And while I'm up here, I would say that MAG has passed policy because we think that access to vaccinations is such an important issue in our current society that this makes sense. The reimbursement rates for giving vaccines has gone down dramatically, and it can make more sense sometimes for patients to go ahead and get those vaccines from their pharmacy. Now, physicians will still carry a lot of these vaccines and will give them to their patients as it makes sense, but we want to make sure that people are getting vaccinated against many of these diseases, especially as we see vaccination rates among some groups going down and things like measles coming back.
Okay, I understand that, but would they be able to, and I understand it's under the protocol with the physician and with the day-to-day deficient physician, I understand that, but with the physician that's over, that they go out and get to say that they can do this and write up a protocol with a pharmacy, that maybe they just pay that physician to be a consultant and they write this up. Will they be able to give things like the rabies
I believe
injections?
that rabies injections are a little.
I think that one time they were listed under our vaccines at one time, or what if we had
It's a very specific subset of the population that would be have the ACIP recommendation for them to receive it. It'd be basically veterinarians, and then, but usually, quite often in humans, rabies vaccines are given post exposure, and that would then be done in typically a hospital.
or something, let's say we had God forbid, an Ebola outbreak. When a protocol, they would be able to give that vaccine?
I would think that in the event that we have an Ebola outbreak, they would be giving it anyway under a public health emergency exception.
Okay, I just wanted to be clear.
Yeah. For most of your very, very new vaccines, it's important to remember that the COVID vaccine is ACIP recommended, but it is currently under an emergency use authorization. So it's a little different than what we have with other vaccines. And there are very specific protocols as it comes to live vaccines about what should happen and the protocols that would exist before you give a live vaccine to a patient and the type of information that you have to give them beforehand.
Okay, thank you. Megan, while you're here and I have a chance to say this to you, and it'll save me a phone call. One of the problems that we've had with the vaccines for COVID is that it's been going to the pharmacies. And across the state, many of our physicians would like to administer the vaccines. And not only would they like to administer the vaccine to their patients who they see on a more regular basis and know all of their comorbidities, but we are now hearing about a lot of people who don't want who want to have their family physician give them the vaccine. They don't, that's the person, that's their medical home. And they don't want nothing to do with the pharmacies or the pharmacists, know that they can't give an injection, but they want it to be from their family practitioner. And yet the doctors across our state are being told that they're not being able to get the vaccine to give to people. So
Yeah. Well, understood. And just so you all know, we did get to a point where we had so many providers that had enrolled in the system and wanted to receive vaccine. And we're at the point where we're just trying to get vaccine out as fast as we can to the people that want it. So we're really focused on the mass vaccination sites. And touching on your pharmacy point, the federal government entered into contracts with a lot of pharmacies, the retail chain pharmacies like Walgreens, CVS, Kroger, I believe. And so they're getting direct allocations, right, from the feds that the state isn't involved in. So just keep that in mind when
Well,
you're thinking about the pharmacies
all right,
as
but
well.
can you send back the message to Dr. Toomey
Yes, absolutely.
that we would like the physicians
Mhm.
who take care of these patients across the state, not just when we're having a pandemic, but, you know, every day of the year, that they would like the opportunity to be able to have vaccines to give to the patients that want their doctor to administer them. And we need to
Mhm.
open it up for physicians' offices.
Yeah, certainly.
Okay, thank you. I mean,
Yeah.
I appreciate what Public Health's done, and I understand about trying to get out as much as we can, but
Right.
um,
Yeah, I think as we get more vaccine available, which we're anticipating, we'll be able to start bringing on those providers that have enrolled. They're waiting for their allocation. So I understand. I'll relay the message.
Thank you for expediting that. Representative Fry.
Thank you, Mr. Chair. Sorry, that kind of caught me off guard.
I'm sorry, I bumped you.
Okay. Hey, how you doing? Thank you
I'm
for
good.
being here today. I got a couple of questions. For the consent question in section 3 that we were discussing that was already existing in the bill.
Mhm.
When you say that consent for statistical analysis would be implied by filling out the form to get the vaccine, I mean, isn't that normal, right?
For statistical analysis of what? Are you talking about the data that goes to CDC?
Yeah, which is, it's earmarked by a birthday, right? And it
Right.
just shows how old they were when they took it, whatnot. That's
I
it,
think,
right?
I think the issue that our general counsel discovered with this is the way the law was drafted. That information that is contained in the registry is completely confidential, except for these very limited circumstances, right? Which is the various medical providers and then the school. So that's why we had to add this language in here. And it's been addressed through EO. So we can share the data with CDC in the meantime, but we're trying to prepare ourselves for the time when the EO is not here.
Yeah, no, that makes a lot of sense. Thanks for doing that.
Mhm.
And one more question, if I may. And then how would, in the section on page 5, how would the pharmacist sign up for the program? Is there
You're talking about the COVID vaccine program?
yes, ma'am, is there an enrollment
Yep.
situation?
So we enroll providers and they essentially fill out paperwork, they go through training, they sign a contract with CDC saying,
Okay.
I'm going to follow all of these requirements and all the rules of the program. And at that point, then they get a PIN number and they can begin placing requests for orders with
Okay.
the state. Yeah,
All right, great. Thank you so much. It's a good job.
you're welcome. Thank you.
Representative Sharper.
Thank you, Chairman. How you doing?
I'm good.
Here I see where you have the code sections 31-11-53, then it skips to 31-11-55. Did you leave out 31-11-54, which it deals with paramedics out for a reason, or is it just, you don't have to have it in, or what do you think?
So paramedics are already allowed to administer injections in accordance with their current scope of practice.
Mhm.
So we did not need to add them here.
Okay, and I see where, because the certified cardiac technicians can do those things. I didn't know if y'all was, adding anything extra beyond that makes sure that the paramedics are aware, of anything different. So I was just wondering why that was taken out versus kind of left in on a bill kind of the same magnitude.
Yeah, so since
Okay.
paramedics are already allowed to do it, we didn't address the paramedic issue in the executive orders, and
Okay,
so we thus didn't address it in the bill either.
okay, thank you.
Could you just briefly, for all the people who may be concerned about the privacy that Chairman
Yeah,
Barr and others
yeah,
brought up,
yeah.
can you just clarify pretty distinctly what the current law is
Yes,
and that this doesn't change any of that,
yes,
but it does change certain information specifically for the public health emergency that would, is an additional release or either a lower or a same or less complete release?
yeah. So under current law, individually identifiable vaccine information can be sent to very specific entities without the explicit consent of the parents or the patient themselves. And that is if the information is going to a health department, a hospital, a physician, or another provider of medical services to that patient. We can send those records. Did you have a question?
Would that be because they would do that? I'm coming up with, we don't have smallpox, but somebody tested, but had smallpox. Then it could go back to their local community and public health if they felt like that's where they lived and they could possibly be facing an outbreak of smallpox.
Mhm.
Is
Yeah.
the kind of situation where any of this direct information would go back. Am I right?
Right. Or for example, if a patient gets vaccinated at a health department and we want to send these records to their primary care physician. This allows us to do it without them specifically signing a HIPAA waiver saying we're allowed to.
Here again, trying to keep the medical home
Yep.
and the patient connected to that
Exactly.
medical home.
And then let me talk about the second exception. That's it. This is all existing law. Okay.
Right.
The other one, it allows public health to send these records to a school or a child care facility. So I have a 2-year-old who was in daycare, and DPH is allowed to send her vaccination records directly to the daycare if they request it, to make sure that she's up to date on all of her vaccines and their records are all straight in case there's an audit. Okay, that's all existing law. The only change is we are also allowing vaccines that are administered under a declared public health emergency. So COVID right now, whatever the next pandemic is, hopefully never, but maybe in 100 years. This allows us to send that data to the CDC.
How specific a data?
So the data that goes to CDC, the only identifiable information is the patient's date of birth. We do not send patient names. We don't send addresses. We do send zip codes. We do send gender, demographic information. So the CDC can have, you guys all like the charts and stuff CDC puts out. So they use that data to put out their charts and their rankings and all of that information that the nation relies on, right, to determine their public health response.
Thank you for that. I think a clear response. Is any other committee questions at this time? Anything else the author would like to add, or maybe not? Sorry, Chairman Barr first.
9. And this may be, again, just to make sure I communicate back to the folks who sent me here. Can you point out, because I am slow, where it says that the exception is to be able to send this to the CDC? What line is that on?
So that is drafted as a third party authorized by law to collect and receive such information for the purpose of averting a serious and imminent threat to life and safety, as long as that third party adheres to state and federal privacy laws. In this situation, it's CDC.
Very good, thank you.
You're welcome.
Anything else to add, sir?
No, I mean, I really do think that Megan's done a good job of explaining what the bill is trying to do and the concerns about privacy, which we went over probably as much or more on the Senate side. So yeah, I understand the concerns. I feel very comfortable that this does what's intended to do, but doesn't go any further than it has to. Thank y'all.
Florida Lot.
Make a motion to pass.
We have a motion and a second. Is there any further discussion from the committee on LC 338753S? All in favor, say aye. Sorry, we have further discussion. Go ahead, Representative Sharper.
Okay, thank you. All right, it's just one thing here that, I don't know, it's probably the same thing on the other bill that we had before. When we're saying emergency medical technicians, you have EMTs, okay, which can't do intramuscular right now. But you do have the advanced EMTs, which is different from a cardiac tech and also different from a paramedic. I think we need to clarify that a little bit better on where it says the EMT part.
Can you tell us what line you're reading from?
14, upon certification by the department, emergency medical technicians may do any of the following. But
That's existing language, right?
yeah, that's existing language. And we're talking about, right now we're talking about COVID, but we're talking about the possibility if something happens again and it's something different, then you need to see if that you can go ahead and do that. But I think one thing could be different is if right now, since the advanced emergency medical technicians can do this, because you have certain levels of, you have a basic EMT that can't do that. And it will be a whole nother training to do that totally. But if you maybe change that to advanced emergency medical technician, it would go within their scope where they already can do these things. And in most companies, if you had the situation, they say we're going to do some drive-throughs and let paramedics, cardiac technicians, and advanced EMTs do the vaccines of COVID or whatever you want to do, you'll be able to do that. But a basic EMT, that's not in their scope. And when you say emergency medical technicians, that includes your basic and your advanced. But I think if you just put advanced emergency medical technicians, then it could be a smooth transition and nobody else will really have to change anything pretty much.
Representative Sharper, would that, if you put advanced there, then the numbers 1 and 2 on line 16 and 19.
Okay, where are you?
On line 16 and then on line 19, those are things that any EMT can do now. Is that correct?
Mm-hmm.
So if we change the earlier word, they wouldn't, the basics wouldn't be included in 1 or 2.
Let's see.
Or 3, but it would take them out of 1 and 2, at least in the language that we have in front of us today.
Right, it's just when it comes down to that 1, 21 and 22 that we're allowing them to do, that's the only difference. You know what I mean? So if you had to change, let's see, while in training become a technician, you would have to change the B to be with advanced, but you can somehow say,
Representative Sharper,
go ahead.
if the committee wants to do that, let's let Betsy say how that would be rather than you try to figure out. Let's let Betsy as the lawyer figure out.
Well, I'm not understanding she's a lawyer, but I'm saying I know this
No, I
industry and I
mean,
know who
Rob,
can do
you
what
brought
as
it.
well.
No, thank you for bringing it up. I'm just wondering, let Betsy figure out if we were going to try to make an adjustment. Now we're going to-
Okay, I mean, that's fine. You okay? Or could you give us a comment now?
Sure. Yeah, my concern would be that the term emergency medical technician is the term that's defined in the code, and it's actually used all throughout this chapter. So if we change it in this one place, then it's, I think, going to have a ripple effect, and we can certainly do it, but I think it's going to be more than we could do right here on the fly. And we don't have the term advanced emergency medical tech is not used anywhere in there. So that would have to probably be defined somewhere. So
And can I address Dr. Dr. Newton, being that basic emergency medical technicians, they can render first aid, resuscitation services as taught. These are things that they can do anyway. So it wouldn't be an issue for us to even have to change that emergency medical technician information. We just need to make this first situation advanced emergency medical technicians so that can be covered, but your EMTs won't have to change anything that they do. And of course, and they can't do the intramuscular anyway. So the easiest fix, this is just my suggestion, is to say advanced emergency medical technicians on the first part of this and keep that like that. And then
Representative Sharper, Betsy is saying that we really can't do that.
okay. Well, I mean, I'm just saying when she get ready to do it. But go ahead and do whatever. You're the chairman. Go ahead.
No. Okay. I mean, Betsy's saying we'd have to take it and rewrite the whole.
Well, we would
Right.
need to define another term.
Term and all.
That it just is a little bit more, I mean, we certainly can do it, but I'm not comfortable doing it right here and being certain that it's going to accomplish what your intent is. So
Yeah.
I'm happy to.
Just for clarification, for example, in 19 and 20, approved under the order of a duly licensed physician, administer IV solutions. You're saying a basic tech can't do that now. A basic EMT can't do that now, right?
Right.
But it's in there now in current code, even though they don't do it because of a different section, because it wouldn't be a legitimate order from a physician.
It wouldn't be in their scope.
It wouldn't be within, right. So it wouldn't be within their scope. So we should be able to rely on the same scope definition that separates advanced and basics. If we're relying on it on number 2 in lines 19 and 20 about IV solutions, I think we could probably leave it under the same allowance during the public health emergency, which is still upon the order of a duly licensed physician. And I do believe, I guess from a public health point of view, is the goal to maximize the number of people who can give this vaccine because of the public health emergency,
Yes.
not like day-to-day.
Yes.
routine
certainly.
things.
And
This is just-
the scope of this is limited, right, to that public health emergency too. And I do understand where you're coming from. I think in code, right, EMTs are, and Betsy, correct me if I'm wrong, EMTs are just defined in one section. They're not broken out by their scope, I guess, within that.
Right. Maybe when they did
Right,
this.
but they are in our regulations.
Right. So at one time you didn't have the EMT, basic EMT and advanced.
Mhm.
You had just the EMTs. Then they created the advanced so that you can do things like this to
Right.
add that extra. But
Right.
All right. Thank you for the review. At this point, we do have a motion and a second on the bill in front of us today. Is there further discussion on the substitute for SB 46? Is there any discussion online? I don't see any hands up online. If so, then we'll take a vote. All in favor of SB 46 LC 338753S, say aye. Any opposed? No. All right. The bill passes. Thank you for your work, sir and ma'am.
Thank you.
Okay. All right. Thank you very much to my vice chair for taking this. Y'all missed the show. I literally slid into rules. They were calling my name as I came down the hall. So I made it. I just couldn't breathe and talk to him for a minute from running over. So I appreciate that. So let's go back to House Bill 474, and I will call on Jeff Breedlove to come and tell us who you are, Jeff, and good.
Thank you, Chairman Cooper. My name is Jeff Breedlove, and I'm a person in long-term recovery. That's who I am first and foremost. And I'm here today on behalf of the Georgia Council on Substance Abuse and behalf formally of the Georgia Overdose Prevention Organization. I also am mindful that there's been a letter of support from the Georgia Harm Reduction Coalition and over 32 recovery community organizations in many of your districts in support of this important bill. The very first thing I want to say is thank you. Thank you to Chairman Cooper. She has more than just a recovery champion. She has been a true leader in breaking stigma and saving lives. And this community is a complicated community. Because look at me. I used to sit at those tables before COVID as a policy analyst for the state Senate. This is a big deal for somebody to speak to you all. I'm one of the lucky ones from my community. Understand that. My disease didn't kill me. It almost did, but it didn't. But these groups, particularly the two groups of moms, one in Forsyth and one in Coweta and Fayette and Spalding, who lost children to this disease, they can't get up here and talk. It's too emotional for them. So I did want to take some time today on their behalf, because it's not a simple bill. It's an important bill. And this bill does one thing at the end of the day. It saves lives. That's what it does. Everything else is just rhetoric. Now, let me be clear. More people were dying from substance use disorder before COVID than anything else. The number one drug involved was alcohol, and the number two was opioids. That doesn't even get to heroin and cocaine, which is my drug of choice, just in case you were curious. Dr. Toomey did a memo on June 19th to Governor Kemp and to the legislature. That was a public memo calling this the epidemic within the pandemic. The number one incidences in emergency departments across Georgia during COVID have been overdoses from substance use disorder and opioids in particular. She followed that up with a second memo verifying that. I promise you not many things, but I will promise you this. This is not because of COVID. When COVID goes away, the only news for my community is we'll go back to being the number one medical issue involved in deaths in America. This is serious stuff. Now, this is a pro-doctor bill. And let me tell you what I mean by that. The CDC and FDA recommend things. Now, I'm not a lawyer and I'm not a smart doctor, but I love my doctor. I've got the best doctor in the state, no offense. She's wonderful. And I volunteered as an ambassador for Grady Hospital in their program. I think doctors are heroes. I think nurses are heroes. I also think they're human beings, and I think they need help. And I think they face increasing pressure, not just because of the pandemic, but with the demands. And I think this bill helps doctors. It protects them. I submit to you, we can discuss in the future, because this is the beginning of a process, I believe today, of why it's good to give them legal protection, to put them in compliance with recommendations by the CDC and the FDA. I do not agree. Our community does not agree that this would in any way hurt doctors to have legal protection. I also believe it helps doctors when they're dealing with patients in crisis. I've heard from doctors, and let me remind you, when I was in treatment in DeKalb County, Georgia, I was in treatment with doctors who are members of an organization in this state that you respect. These doctors are back at work today. Doctors are not immune from my disease. And I've talked to those doctors. And I know that they appreciate every help they can get. And sometimes it helps a doctor say, I know you may not want this. I may not want to give it to you, but it's the law. Let me just give it to you in case you need it. And when that crisis is over and they're thinking more clearly, they're glad they have it. So this is a buffer to help doctors explain why they're doing it. Now, we can all produce reports I'm not going to today. I'm going to reference one that I saw that points out that nationally and in Georgia, Georgia's less than 50% of penetration on these life-saving drugs being prescribed. I'm sure there are reports that will show different. It's not really about that. I normally don't make notes, but I'm speaking for others today. And I want to also explain about those others. Georgia believes there's 800,000 people in recovery. There's certainly more. The federal government says there's 26 million people. There's certainly more. Anonymity is a big part of it. How do you really know? Too many people are dying every day from this. That's a premise I hope we can all agree on. Now, I respect whatever concerns the side opposite might bring up, because I think there are heroes. But I will say this, whatever concern there might be, whatever aggravation there might be, whatever resentment there might be at being told what to do, this is what I would say to the governor and to the members of this General Assembly. None of those concerns, aggravations, frustrations, or even anger can hold a candle to a Georgia family that will bury the next person who dies from an overdose. We must do everything we can during an epidemic to save lives. Everything we can. So we start with this discussion. We start with this bill. We're not going to have a vote. We understand that. No one wants to burden doctors. We love doctors. But we do want to say to doctors, and doctors need to hear this, and you need to hear this, the status quo is not acceptable because there's too many death certificates. So we've got to do something. We want to contribute in a positive way to what that something is. We anticipate that there'll be good faith discussions and negotiations as we move forward. But something's got to change. Something's got to change. Again, I come on behalf of tens of thousands of families, recovery communities in Augusta and Rome and Gainesville, Gwinnett County, and all over the state, Cobb County, begging you to treat this more than just a simple bill, hoping that you'll respect the doctors, but hoping you'll respect this community too, and hoping that we'll negotiate in good faith to find an answer that saves lives. We thank you for your time. We love you. We respect you. You have the prayers and good wishes, Madam Chairman, of many thousands who you've helped. And this is a wonderful bill, and we hope that there'll be a way to get all sides to support it in the end. Thank you.
I have a question, but we started. We have a standing order now from Dr. Toomey in Public Health that any family member, any mother or all can go to a pharmacy and without a doctor's order, get Narcan. Why, standing order, that just walk into the pharmacy. It seems that they're not doing that. Why do you think that's not happening?
That's a great question. And I want to try to treat it as seriously as I can. I was in active addiction for 30 years. I think the thing that almost killed me the most was the stigma more than any other drug. The stigma is real. Families have shame. And this is for a different discussion in different days, but please understand the word is stigma. There's shame, there's fear, there's denial. There's discrimination and prejudice against people with my disease. That's why so many people need anonymity. Now, Georgia's making great strides, and this administration and this General Assembly has worked bipartisanly. The Working Group on Addiction and Recovery, Eric Allen chairs it in the House, Senator Kirkpatrick in the Senate with Randy Robertson. It's one of the few bipartisan coalitions down here. We know it's not a partisan issue, but it's stigma. And I will tell you this, Madam Chairman, we're here to support this bill because we just believe that during an epidemic, families need all the help they can get. When your loved one, if my mom was here or my wife was here, I've heard their testimony. They're afraid to ask. They don't know what to ask. Sometimes when you're in crisis and the life is at stake, you just need your doctor to say, here, take this. It will work. Not your pharmacist, your doctor. Doctors are heroes. And that's true. But sometimes being a hero requires some extra responsibility. So the answer isn't always voluntarily going in when your emotions are out of whack, you're not thinking clearly, and going, oh yeah, there's a memo that says, that's not what happens in the real world. But when they go to their doctor for help, where most people go, having a doctor say, this is it, this will save your life. Some doctors may do that today, but I hope nobody would stand up before you and say, to any level of satisfaction for the people of Georgia. And we've got to find the right answer.
Well, I certainly hope that the recovery groups would put it out there and make it well known that Narcan is available to people who want it. And I would think that, I mean, not saying that we need to look at other things, but it's out there, it's available. Family members are often the ones that need to have it rather than the addict themselves, correct?
Correct. Oh, absolutely. Yes. ma'am.
Okay, so, I mean, if there's a stigma to it, if you send in a prescription that you write at the same time, somebody still knowing that the person having it is getting it,
Yes,
and needing it, and the narcotic or the Narcan. I just think that we need to let people know that that's available. It's something I'm
We
right
couldn't
now
agree
that I'm
more.
talking about
Yes,
is
ma'am.
that
And I know you join me in saluting the good work of the ladies with Georgia Overdose Prevention. They have a statewide network of volunteers that literally walk the streets in your districts,
giving it
giving it out
away.
over and over. And we thank private sector Georgia businesses who in often cases pay for it. And we thank the federal government and our Georgia delegation who have provided funding for it. It's still not enough. But we hear you. We can always do more as a community. And our pledge to you is we will do more as a community. We just need doctors to help too. This is not a silver bullet. A doctor could give a prescription to Jeff and his stigma he may not do it, but he might give it to Sharon, and it might be just the thing that saves her life that day. I don't think this is a silver bullet piece of legislation at all. I think it is a step in the right direction. And at the end of the day, I think it saves lives without raising taxes, without undue burden on doctors, and in a manner that allows doctors to once again play their role as the people of Georgia look to at the end of the day for help in a medical issue, of which substance use disorder is an important and legitimate medical issue.
Representative Newton.
Chairman, thank you, ma'am. I think you answered one of my questions, which was what's the current policy that do you need a prescription currently? And my understanding is you don't.
Correct.
And it sounds like it's available. I appreciate some of the changes that were made in the substitute, but I do remember at some point there was discussion that the patient who's going to get the prescription for the opiates that meet the definition, typically I assume the patient picks up the medication, they could currently ask for Narcan and get it. If they can refuse it according to this law, right? I understand they can.
That's my
refuse.
understanding too. So they could refuse it.
So they can decline the prescription, whether for whatever reason.
Correct. I think so.
What if the physician, just for the lightest touch possible, we just encourage the physicians to tell them to ask the pharmacist for Narcan instead of a lot of thou shalts? Because I mean, it would accomplish the same thing. You should really have Narcan around with the amount of medicine
Yes, sir.
I'm prescribing for you. Or
Yes, sir. Now, I respect you, and it took me 7 years to learn the importance of the words may and shall, right? We understand what those words mean. This is what I would say to you. 9 times out of 10, I would say, why would we suggest that we tell doctors that they need to abide by the word shall? But I would say to you, in direct answer to your question, there's just too many deaths happening. And I don't think that if the recovery community is not doing enough now, I also don't think the medical community is doing enough now. And if this will help save one life, and it will save more than one life. When I was at my worst, or even at my best in active addiction, we're not thinking the way healthy people are thinking. It's a mental disease, right? So we're in all kinds of denial and conflicting things. And having a doc tell you, you need this, will make a difference. Now, this is a hearing only today. Certainly, if the chair and this committee invites further conversation, I'm sure we can go deeper and deeper into that philosophical question you just asked. But I would just say today, we begin from the point that telling doctors this is telling doctors, it doesn't in any way insult the doctor who wants to save lives. But look, the old joke, what do you call the doctor who graduated last in their graduating class? Doctor, right? No one's talking about the doctor of the month at MAG. No one's talking about you. But what about the doctor that gets busy and forgets? What about the doctor who doesn't believe in recovery? They're out there. I've heard that from other doctors who are in recovery. So if we can compel one doctor who may not be where the doctors who believe in recovery are, in that most rural area, maybe where there's not everything that's right here, and we save that one life, I'm okay with the word shall. I understand others are not.
I appreciate it, and maybe something that can be worked on in between the hearing time and
Absolutely.
in the future,
Yeah.
this list of things that the concurrent benzodiazepine, increased risk of overdose, a history of overdose. I'm looking at it from a practical point of view. Just maybe we can work on the language to how a doctor's going to know this one needs it, but this one doesn't meet Georgia's criteria. Electronic prescribing is growing every day. And I think there's ways to put things in there. Our
Yes.
current system automatically checks the PDMP when I write any kind of a narcotic. So the systems are better. I think it can be worked out, but maybe give some thought to that before on how the actual implementation of when it is mandated and when it's not mandated would
Yes,
be
sir.
implemented.
Absolutely, sir. My commitment to you is we will certainly do that in particular. And we would say this to every member of this committee and the General Assembly and our friends in the doctor community. Whatever attention we can get, whatever effort we can get to explore questions just like that helps save lives. Whatever bills we can perfect, whatever new bills we can bring forward because of this discussion today may save a life. So we're honored to work with you to explore those details where we would learn from doctors' expertises, how we can support the doctors. Our bottom line is this: too many people are dying. This bill will help save lives. Sharon Cooper has helped save lives. And we're up here to remind you, as important as doctors are, the families who are bearing their children are important too. And we need to help them.
Well, I can tell you one of the problems that I had, Dr. Newton pulled up the cost. And you can write a prescription, and even if you want to go get it, Narcan's $123. And an opioid prescription is what, $11. I mean, it seems a little bad. The company's at $123 for Narcan.
Yes, ma'am. I mean, we're with you on that too.
I
We'd
mean,
love to work on
you know,
legislation
And the other problem I have,
fix
and the
that.
bill just passed out of the House and is over in the Senate, putting somewhere like 12,000 more prescribers prescribe opioids and
Yes,
not
ma'am.
Pete from,
We testified against that bill too. I don't
Okay,
think that's appropriate, but
I
we
mean,
are
I
not in
have-
favor of that bill.
it's not that I don't think a PA or an APRN is not capable of ordering, but why in the middle of this epidemic, and of course I didn't vote for it, why in the middle of this epidemic would we put 12,000 or more prescribers on to order Schedule IIs?
We couldn't agree with you more, Madam Chairman.
I mean, I just, I'm just having a little trouble with the cost of the drugs, the fact that we're putting more prescribers out there to prescribe it and it's just a problem.
Well, Madam
Thank you
Chairman,
very much.
Thank you.
And-
Yeah, let me just end by saying, again, thank you again. Thank each of you again. There was a commission on mental health. After this session, our community will be looking to have a commission on substance use disorder. It deserves the same level of attention. The cost of the number of deaths. All of these are great questions, and we need this General Assembly to tackle this issue once and for all head on. I will tell you this. There's a hurricane off the coast. And when this pandemic's over, at the bottom line, you're going to see budget realities, public safety realities, education realities, faith realities about substance use disorder that are going to hit in a way that's historic. We need to get ahead of this as a state. We need more leaders like Chairman Cooper. We thank you so much.
I'll be glad to put in the bill for the commission on substance abuse. That's okay. Bethany Scherer.
Thank you, Chairman Cooper. I'm Bethany with the Medical Association of Georgia, and I thank you for bringing a bill on this important issue. We do agree wholeheartedly that access to naloxone is a wonderful tool in the battle against the opioid epidemic. We are concerned about increasing mandates regarding opioids in general. As we watch the statistics around opioid prescribing, we've seen that between 2014 and 2019, we had a 27% decrease in Georgia in opioid prescribing. Unfortunately, that's not having the result that we're after, which is essentially that what we're now seeing is a dramatic increase in overdoses related to illicit drugs, whether that be fentanyl or stimulants, whatever that is, that are not obtained through the legal market, so to speak. And so we look forward to having a really intentional discussion about how we can address all of the factors that go into the opioid epidemic that we are currently facing, and how we can have better policies as a state that address the systemic issues that are behind opioid overdose, and not just addressing prescribing, because there are two sides to this issue, right? We still have patients who are experiencing excruciating pain. We have, whether it be cancer patients or just chronic pain patients, that right now, part of the problem is that, like you said, an opioid prescription is $11. How much would it cost that same patient to obtain physical therapy or occupational therapy or cognitive behavioral therapy in lieu of those prescriptions? It is very difficult to find a different tool that is a non-opioid to treat a patient's pain, especially if that patient doesn't have great insurance or any insurance. Additionally, we would like to see ways to improve access to the naloxone that is already available, essentially over the counter under the standing order that we wholeheartedly support, and make sure that the financial aspect of that is accessible to all patients, and not just the patients, but the family members of people who are concerned about their loved ones, because that's really who we need to get this in the hands of. We need to get it in the hands of roommates, parents, siblings, whoever that might be, that is most likely to be around that patient if they, happen to overdose.
Okay, questions? Okay, thank you very much. Greg Rabo, you here? Okay, come on. Let's hear from the pharmacy group.
Thank you, Madam Chair. And, Frank, first of all, appreciate the legislation and the conversation. My folks have yet to really have a position on it. I think, as a general rule of thumb, pharmacists love naloxone. No question about that. I know, Ira Katz at Little 5 Points, and he gives it away. And he's actually personally administered it and saved lives. So we do have pharmacist members that give it away. I have a couple of thoughts, and this isn't even the Pharmacy Association itself. This is, as a healthcare lawyer who works for the association, but I do have some concerns about what happens when you're talking about like patients who are coming out post-procedural and you have an opioid prescription, but then the Narcan prescription doesn't come with it. Is that a legitimate prescription? Isn't it? So I think that there's certainly technicalities to work out and would welcome those conversations. And I'd also note that talking to a lot of my members about it, what they find is that price point is really a major factor in patients getting it, right? We've got pharmacies and we've got Pharmacy Association material about the importance of Narcan and naloxone. And we have pharmacists that have those conversations, right? And don't forget that standing order is broader than just, hey, when a patient is filling an opioid prescription, it could be a mom who's concerned about her son. It could be a brother who's concerned about a sister, right? It's broader than just somebody who has an opioid prescription, that standing order, which is a really good thing. But boy, price sure factors into that, right? And I actually had a conversation about 2 years ago with an executive for one of the companies that was really expensive, and flat out asked him, hey, why is it this much? And you know what the answer is? I'm a broken record on this, y'all. So, but PBM rebates, right? To get on the formulary, they're demanding upwards of 50% rebates to get Narcan on the formulary so that patients can access it, right? And so I think this is a critical conversation to have, this bill, and we look forward to having it. But I also think that price is something else for us to look at, right? Because a physician who's kind of mandated to write this, if the patient isn't mandated to get it dispensed, right, it's going to be cost, it's going to be price. And so I think that's we can't ignore that part of the conversation either, which is the cost of this.
Some of the other states have, mandated that things like insulin can't go over a certain price.
Yes.
Any state ever done that about Narcan?
I don't know, but I'd sure be interested, and I'm happy to look at it if you'd like me to.
Looks like that might be a real interesting thing to explore. Insulin is certainly important for people, but Narcan can be much more of a lifesaver. I mean, insulin also, you have to have it for your life, but in the situation of that's one of the.
Yes, I think it's definitely worth looking at. The insulin obviously is an issue where insulin is not a new drug and it's been around forever. And how does it continue to skyrocket?
Right.
And as rebates have gone up, PBM rebates to get on formularies, so has the cost of insulin, right? And so I think that's certainly worthy legislation. But from the Narcan perspective, I'll certainly look at that. I don't have an answer in terms of if other states have capped it, but I can tell you that I've heard from my members, because again, if there's a risk here, there's no question naloxone, Narcan, it saves lives, right? It's fantastic. But price seems to be a pretty significant barrier, even with that standing order.
With people getting it. Okay, we are going to be discussing this at length, and
we appreciate
going
the
forward. And
opportunity.
if you would check on that information. I think one of the things, I don't know whether the members know, but we're hearing more and more often, and this is because of the illicit drugs, that one shot with an Narcan is not enough, that the first responders are often having to use 2 or even 3, and they don't always even work after that. And, what responders, what community, even some businesses buy the Narcan from them often don't carry that much Narcan with them on an individual basis. So it just goes to show the severity of the problem with trying to combat this terrible pandemic. So thank you very much.
Thank you.
Any other questions from the committee or anybody else that would like to speak? Seeing none, I mean, be glad to put a bill in next year for the commission. If that going forward, if that's what the community wants, I think we do need to work on that. And we will be discussing this as we go forward, over the interim. So thank you very much for everybody. Thank you for your testimony, and we are adjourned.